Assalamu alaikum. I am Dr. Rawnak Afrin, working in Bangladesh Atomic Energy Commission for 16 years. With the kind permission of chairpersons, I want to deliver my speech regarding clinical utility of 18F FDG PET-CT imaging for evaluation of non-small cell lung cancer, a 5 years prospective analytical study in Bangladesh. Lung cancer is one of the most aggressive malignant tumor with high rates of morbidity and mortality worldwide. Non-small cell lung cancer accounts for about 85 to 90% of the lung cancers. Several factors including histopathological variety, stage at diagnosis, and treatment modalities are limited with the prognosis as well as with the survival. So findings new diagnostic and prognostic approaches is critical for improving the capacity to predict outcome. Adenocarcinoma is the most common histological type of non-small cell lung cancer, and it is more prone to EGFR mutations than other subtypes. EGFR mutation plays a crucial role in tumor aggressiveness and response to therapy in non-small cell lung cancer. And EGFR mutations also make those tumors sensitive to EGFR tyrosine kinase inhibitors. Until now, these are the available treatment options for a lung cancer patients. And FDG PET-CT is regarded as the standard of care in the management of non-small cell lung cancer. It is a useful adjunct in pre-treatment staging of non-small cell lung cancer. It can help in the differentiation of lesions that are equivocal after conventional imaging. Objectives of this study is staging of the newly diagnosed lung carcinoma patient with FDG PET-CT to determine the diagnostic and prognostic value of baseline PET-CT in newly diagnosed non-small cell lung cancer patient to evaluate treatment response and re-staging. This prospective analytical study was conducted in 2 centers of Dhaka city for a period of 5 years. A total 450 patients who had histopathologically and immunohistochemistry proven newly diagnosed non-small cell lung cancer were included in this study. Ethical clearance was taken from Institutional Ethical Committee of Dhaka Medical College Hospital, and written informed consent was taken from each patient. A two-marker panel of TTF1 and P63 was used for subtyping adenocarcinoma and squamous cell carcinoma. Whole body PET scan was acquired from vertex to mid-thigh in a 128-slice whole body PET-CT scanner, 1 hour after intravenous injection of 5 to 10 millicurie of FDG. In each stage, International Atomic Energy Agency guideline is maintained. As poor patient preparation leads to poor images, so adequate patient preparation rules were strictly followed. 8 to 12 hours empty stomach prior scan. Patients were advised to take high protein, low carbohydrate diet day before scan, avoid caffeinated beverage, keep hydrated, avoid exercise, journey, and take rest after administration of FDG. And TNM8 staging were used in my study, medicinal node mapping for staging. In our study population, 75% were male, 25% were female, 55% patient had primary cancer in right lung, 45% in left lung, and maximum 38% patient were in age group 60 to 69 years. Among our male population, 70% were smoker, 30% were non-smoker, and our female population, 56% were from urban areas and 44% were from rural Bangladesh. And among these rural female, 62% had history of cooking firewood for cooking, so it may be a contributing factor in rural areas women. And 58% patient had adenocarcinoma, 38% squamous cell carcinoma. In our study, maximum 45% patient had stage 4 disease at the baseline PET-CT scan. And PET-CT can detect other additional metastatic site. 48% patient had mediastinal and hilar lymph node metastasis. 34% patient had ipsilateral and contralateral lung metastasis. 42% patient had musculoskeletal metastasis followed by other sites. And FDG PET is less sensitive in detecting brain metastasis. And among our adenocarcinoma patient, 65% patients showed elevated serum carcinoembryonic antigen level, and those patients were mostly in group stage 3 and stage 4. So serum carcinoembryonic antigen agent might be used as serological marker in case of patients with lung adenocarcinoma. And after baseline pre-treatment staging of FDG PET, 40% patient, in 40% patient, treatment plan had changed, including decision of thoracotomy. And PET-CT proved 98% sensitivity, 94% specificity, and 98% overall accuracy in staging of stage 4 disease. Adenocarcinoma patient showed SUV max range 4 to 25. Squamous cell carcinoma showed SUV range value 5 to 35. So squamous cell carcinoma showed higher SUV max value. And it's my opinion that maybe O positive blood group is with increased risk of lung cancer among Bangladeshi population, as 42% of our study population had O positive blood group. And 20 patients of this study had history of COVID-19 infection, hospitalization, diagnosed as CORAD 5 by HRCT, followed by PCR confirmation, and developed C lung within 18 to 30 months. So long time study is needed in this aspect. And among our adenocarcinoma patients, 70% has EGFR wild type, 30% had EGFR mutation positive, and 90% patients showed classical EGFR mutation, that is EGFR 19 deletion and EGFR point mutation in exon 21. And in this study, SUV max value was higher in the patients having wild type EGFR than the mutant type. The size of the primary malignant lesion and stage of the EGFR wild type group were significantly higher than those of the mutant group. EGFR mutation found more in non-smoker and female patients. And in this continuation, my research on PhD thesis is going on to find out the metabolic parameter, metabolic tumor volume, and total lesion glycolysis in association with oncogenic driver gene mutation in lung adenocarcinoma patient to predict progression-free survival and overall survival on the basis of PET-CT metabolic parameter and EGFR mutation status. PET can detect all the accurate staging before pre-treatment option, and PET can also clearly detect complete metabolic response, partial metabolic response, stable metabolic disease, and progressive metabolic disease. A 60-year-old male patient presented with pathologically proven adenocarcinoma had wild-type EGFR mutation. We can see the primary lesion in right lung and also had nodal metastasis and skeletal metastasis. After completions of chemotherapy and radiation therapy, follow-up can show progressive disease, the morphometabolic progression of primary lesion, and also the metastatic lesions. A 52-year-old male patient presented with pathologically proven adenocarcinoma lung. He had positive EGFR mutation, 19 deletion, and after completion of chemotherapy and the patient was on TKI therapy, we see that near complete morphometabolic regression of the lesion, and the patient had progression-free survival for 24 months. And after that, he had a reappearance of FDG avid lesion. So at this point, we done a dual point PET to confirm as it is a malignant lesion, and we clearly see 2 hours after tracer administration, delayed scan show interval metabolic progression. So PET-CT is a useful adjunct in pre-treatment staging of non-small cell lung cancer. It can reduce both the total number of thoracotomy and the number of futile thoracotomy. It is an excellent tool for response evaluation, re-staging after neoadjuvant treatment, detecting tumor recurrence, and guiding radiation therapy planning. PET can discriminate more accurately whether the residual disease is a metabolically viable tumor or scarring, and pre-treatment SUV max of the primary lesion is significantly associated with prognosis and overall survival in patients with advanced non-small cell lung cancer. And my study is partly funded by a special research grant from the Ministry of Science and Technology, Bangladesh. I would like to express my special thanks to my guide and co-guide and my mentor, Professor Dr. Shamim Momtaz Firdousi Madam. She is present here. So thank you all for patience hearing.